Our next presentation is titled Proteomic Biomarker Discovery for Acute Pulmonary Embolism, presented by Dr. Drew A. Birrenkott at Brigham and Women's Hospital, Harvard Medical School.
Fantastic. Thank you very much for that kind introduction, and thank you all for being here. It is an honor to be here among so many esteemed emergency clinicians and to get to share our work on proteomic biomarker discovery for acute pulmonary embolism. I would like to especially thank and acknowledge my co-authors, without whom this work would not have been possible. We have the following disclosures. As emergency clinicians, we do many things, but universally, for every patient, we make a diagnosis from a set of undifferentiated signs and symptoms. We are acute diagnosticians. In the era of omics and machine learning, there is tremendous opportunity for diagnostic innovation. As emergency clinicians, we should own this science and be driving this innovation. Currently, the evaluation for PE includes estimation of pretest probability, protein biomarker testing with the D-dimer, and imaging. The problem is that the D-dimer is poorly specific, which has contributed to a 450% increase in imaging for PE in the last 20 years. This imaging is time-consuming, increases radiation and contrast exposure, and leads to possible false diagnosis. In short, we need better biomarkers. Fortunately, the proteomic technology now exists and allows us to simultaneously screen thousands of proteins to identify new biomarkers. We already use protein biomarkers every day in emergency medicine. For example, troponin, lipase, and of course, the D-dimer. The D-dimer only measures clot degradation, while proteomics allows us to simultaneously consider multiple biomarkers and more completely describe the complex hematologic, cardiovascular, and pulmonary pathophysiology that occurs when a patient has a PE. The aim of our study is to use two expanding technologies, proteomics and machine learning, to identify candidate biomarkers for acute PE diagnosis. The data we use for our study is our novel PE biobank. To create this, we recruited ED patients, all of whom were assessed by an emergency physician and worked up for a PE. For our analysis, we selected 86 patient samples, 30 controls without a PE, and 56 who were diagnosed with a PE. We evaluated our samples using the Olink Explore HT platform, which assesses relative protein expression levels for 5,419 named proteins through their proximity extension assay. This process uses two unique DNA-tagged antibody pairs for each individual protein. When both antibodies bind the protein, they cause DNA hybridization, which allows for PCR amplification and next-generation sequencing for measurement of relative protein expression levels. To identify candidate biomarkers, we applied a validated proteomic pipeline. We first divided our data into training and test set. After division, we identified proteins that had a statistically significant expression in PE versus control using univariate t-testing. Next, we corrected for multiple testing, selecting markers with a false discovery rate less than 0.05. We then used these proteins to train 3 different supervised machine learning models: XGBoost, Random Forest, and ElasticNet. Hyperparameters were tuned using 5-fold cross-validation. Finally, we applied these models to the test set to identify the best performing model. These two tables show the demographics and PE risk factors for our population. We note that they are similar in PE positive and negative samples, the one exception being a slightly higher percentage of PE-positive samples with active malignancy. Overall, we had exceptional sample quality. We only had to remove one sample due to poor quality and were able to fully quantify 81% of the proteins in the remaining samples. After univariate t-testing and FDR correction, we identified 49 proteins whose expression was significantly different in PE-positive versus negative samples. The relative expression heat map for these 49 proteins is shown here. Using these proteins, we trained our 3 machine learning models. Our best performing model, based on cross-validation, was the XGBoost, with a classifier accuracy of 93%. The AUC for this model was 0.82. Even considering our small sample size, the AUC is similar to or slightly better than the AUC reported for the D-dimer. This volcano plot shows the expression fold change versus the univariate t-test p-value for each measured protein. The proteins in the blue and red boxes represent those that were considered both biologically, with a greater than 2-fold change in expression, and statistically significant, with an FDR less than 0.05. Samples in the red box were upregulated in PE, and samples in the blue box were downregulated in PE. We selected the 8 proteins with the highest statistical significance as candidate biomarkers and further evaluated their function. All of these proteins were upregulated in PE. All 8 of our candidate biomarkers have a function which foreseeably could be upregulated in PE. 3 markers were related to angiogenesis, 4 markers related to cell growth and differentiation, and 1 marker related to coagulation. While our results are encouraging, our study does have a few important limitations. As a pilot study, our sample size was small. Our plan is to conduct a larger analysis for further expansion and validation of our results. Additionally, it is possible that the biomarkers identified were upregulated due to a precipitant of PE, such as malignancy, as opposed to the PE itself. Finally, many patients in our sample were anticoagulated prior to biobank blood draw, which may have affected proteomic results. To evaluate the effect of anticoagulation, we created 2 PESVIT models, one with and one without adjustment for anticoagulation. Overwhelmingly, the majority of proteins had a better fit in the model without anticoagulation. So we think it is unlikely that anticoagulation significantly altered protein expression. Our study provides promising initial data that together, proteomics and machine learning offer a feasible pathway to biomarker discovery, and that a new diagnostic biomarker panel with better test characteristics than the D-dimer is possible. Our work is a preliminary foray into precision diagnostics. Moving forward, we hope to further characterize our identified biomarkers and combine them into a robust diagnostic multi-protein biomarker panel. We also plan to explore whether protein biomarker panels can be improved and personalized by including clinical data with proteomic data in our models. To this end, with our colleagues at Vanderbilt University, we are building Archive, a robust multi-center emergency department registry of patients evaluated for PE, and we're looking for collaborators. As EM clinicians, we are acute diagnosticians. It is clear that omics and machine learning will change our approach to acute diagnosis. We are at a juncture where we have the opportunity to drive the diagnostic innovation that is the future of emergency medicine. Thank you all very much for your attention. Please feel free to reach out, and I'm happy to take any questions.
Thank you, Dr. Birrenkott.